Thank you very much. My name is David Murphy. I'm one of the consultant radiologists here in Vincent's, and I'm going to talk today about the role of the radiologist in imaging patients with cancer of unknown primary. And I'm going to start with a case of a young woman who presented with left hip pain. And she had an outside MRI which showed a large destructive lesion centered around the left iliac bone. And on T2 weighted imaging, this lesion was intensely T2 hyperintense with a further focal lesion in the proximal left femur, which looked very suspicious for metastasis. And based on these initial MRI appearances, we were highly suspicious that this patient had a primary bone tumor. So a biopsy was performed under ultrasound guidance of the large left iliac crest mass, which revealed actually an undifferentiated carcinoma. So next test was a CT thorax abdomen pelvis, which again demonstrates this large destructive mass centered in the left iliac bone, and also demonstrated multiple liver metastasis, but no actual definite primary site was identified. There were also several further vertebral body bone metastasis. So next in diagnostic test was a FDG PET-CT to try and find a primary source. And this demonstrated that the liver and bone lesions were intensely hypermetabolic with several further bone metastasis, but no convincing primary site was identified. And this is a fairly this was a fairly typical example of metastatic carcinoma of unknown primary. And this type of case can present to the radiologist in varied ways. It can be with primary imaging for a patient where the symptoms are highly concerning for metastatic disease, or with abnormal primary imaging, which is highly suggestive of metastasis, such as a destructive lesion on a plain film, or multiple lung nodules on a chest CT. And this is an example of a chest radiograph with multiple bilateral pulmonary nodules and masses, and you can see them again on CT, and this was metastatic colorectal cancer. So the role of radiology in the workup of patients with cancer of unknown primary, radiology plays a key role in both the initial evaluation of disease extent and obtaining tissue samples, and then in identifying certain subsets that may require further additional workup. CT is the first line investigation, although it hasn't been particularly well studied, partially because it's been around for so long. And this is a study from the early stage of multi-detector CT, which showed that a CT abdomen and pelvis identified a primary site in about 25% of patients who had metastatic disease, but negative primary on initial baseline investigations. And the standard protocol would be to perform a CT thorax abdomen pelvis with oral and IV contrast, with an arterial phase acquisition of the thorax and a portal venous phase of the abdomen pelvis. You may have to adjust the abdominal imaging depending on the initial imaging characteristics, and add an arterial phase if there's a suspicion of unusual liver lesions. Like this is an example of a patient with multiple hyper-enhancing liver lesions, and this was metastatic neuroendocrine tumor. And then the field of view can be expanded to include the neck or brain depending on the clinical presentation. So at the initial CT evaluation, the main key role of the radiologist at this stage is, one of them is to suggest a non-malignant diagnosis. And this is a patient who was referred with an abnormal chest radiograph showing multiple bilateral pulmonary nodules. And you can see on the CT that she has a large subpleural mass in the right lower lobe and these multiple bilateral upper lobe peribronchovascular nodules. When you closely at the one in the posterior segment right upper lobe, this actually has a very characteristic galaxy sign appearance for sarcoid, and this was confirmed on tissue biopsy. So another important role in the initial CT evaluation is to identify specific more treatable tumor subtypes, such as lymphoma or germ cell tumor. This is an example of a young patient with a very large right retroperitoneal mass, and this was diffuse large B-cell lymphoma. Another case taken from the literature of a young gentleman who presented with dysphagia and CT abdomen pelvis, so these large necrotic retroperitoneal nodal mass, multiple bilateral pulmonary metastasis, and this appearance was highly suspicious for a germ cell tumor, which is confirmed on ultrasound of the testis. Another important piece of information the radiologist can provide is to suggest a biopsy target and what the best approach, whether it be an image-guided biopsy like a CT-guided biopsy, or endoscopic, bronchoscopic, or surgical, and this can often be ascertained at the initial CT. Image-guided biopsy is a safe, accurate way of obtaining tissue specimens. Generally, core needle biopsy is preferable over cytology. This is a gentleman presented with right shoulder pain, and initial CT examination showed this large destructive lesion centered in the right humeral head and involving the acromion. Biopsy showed an undifferentiated carcinoma with no definite primary site. And he had a repeat CT, which showed this persistent area of consolidation in the right middle lobe. We looked closer, you could see an endobronchial cutoff sign in the right middle lobe segmental airways. And with that and its persistence, we were suspicious that there was actually a mass-like lesion at this location with some downstream atelectasis. So we performed a CT-guided biopsy of this opacity, and this demonstrated a lung primary. So changed the diagnosis to a metastatic non-small cell lung cancer. CT is often sufficient to help choose a biopsy site, and we will preferentially target soft tissue sites over bone, as this can sometimes preclude further molecular analysis. FDG PET-CT can be quite helpful pre-biopsy in some patients to help target the most metabolically active lesions, and can increase tissue yield for genomic analysis in certain tumors. FDG PET-CT is widely established now in the field of oncology imaging. It takes advantage of the Warburg effect with high rates of anaerobic glycolysis in tumours. And it is very attractive in imaging patients with cancer of unknown primary, as it provides whole body imaging, which can be extended to include from vertex to toes in certain circumstances. This has been looked at in cancer of unknown primary in terms of its ability to find the primary site. And these are now slightly older systematic reviews, which showed tumor detection rates in the region of about 30%, with relatively good sensitivity and specificity. This is an example of an FDG PET-CT with a patient with a small cell lung cancer with multiple bone metastasis. A more recent meta-analysis of the role of PET, of FDG PET, of just under 2,000 patients, so that above standard CT imaging, the FDG PET had a pooled median detection rate of about 40% in finding the primary site. There is a lot of heterogeneity in these studies, as they were majority retrospective. The diagnosis wasn't standardized, but it does suggest that employing PET at an early stage in the workup of these patients may help obviate further diagnostic procedures. But there isn't a proof yet of improved outcomes, and it is unclear exactly where it should fit into the imaging algorithm, although I would suggest that it kind of falls right in behind a CT tap. One case where it is of definite benefit is in patients who present with a malignant cervical adenopathy with squamous cell carcinoma, likely a head and neck primary, but no primary site found, as an example of a patient with a right tonsillar tumour. FDG PET-CT will identify the primary site in about 50% of these patients, and really helps target sites for endoscopic biopsy for head and neck surgeons. And this performs much better than either contrast enhanced CT or MRI in detecting primary sites. So PET is beneficial if it can help improve change patient management, shorten diagnostic pathway, and reduce unnecessary investigations. But it is not a panacea test. There are challenges for it. First of all, its availability can be quite limited. It's limited to just a few centres usually. An FDG, you have to remember, is a non-specific tracer. It can sometimes be difficult to distinguish malignancy from infection. This would be a fairly standard example of metabolically active cervical and mediastinal lymph nodes in a patient with sarcoid. You can also get physiological uptake in the GI tract and urinary tract, which can make it difficult to detect primary sites in these locations. This is an example of diffuse bowel uptake in a patient on metformin. And also you have problems with patient preparation sometimes, and this is a kind of an example of a patient with physiological brown fat uptake, which obviously makes the scan quite difficult to read. Not all tumours as well are FDG avid. This is a case taken from the literature of the gentleman who presented with malignant left cervical adenopathy. Biopsy showed an undifferentiated metastatic carcinoma, and no definite primary site was seen on PET, but was presumed to be a lung primary and treated as such. Subsequent follow-up imaging showed an enlarging left renal lesion, and repeat biopsy of this and also the neck showed that this was actually a metastatic renal cell carcinoma. When you look back at the initial PET, you can actually see a contour abnormality in this location, but it doesn't show any tracer uptake. And renal cell and HCC would be fairly classic of having very variable levels of FDG uptake, so cannot be reliably excluded just on the PET. And we now have other tracers at our availability when required. This is a patient who presented with abdominal pain, and ultrasound showed these hyperechoic liver metastasis, and biopsy revealed a metastatic neuroendocrine tumor. And on CT, we can see a metastatic mesenteric nodal mass, but no definite primary site was identified. So a gallium DOTA PET was performed. And this shows increased tracer uptake in the liver metastasis, in the mesenteric nodal lesion, and also then in a focal loop of distal ileum. And when the CT was re-examined, you can actually see a focal area of small bowel wall thickening, which corresponds to the site of the primary small bowel tumor. And gallium DOTA PET is very useful in identifying primary site in patients with metastatic neuroendocrine tumor. And it is also useful in patients with suspected neuroendocrine tumor where on clinical and biochemical workup where a primary site can't be found. And sometimes resecting for carcinoid tumors, resecting the primary site even in the presence of metastatic disease can improve symptoms. This is an example of a gallium DOTA PET which revealed an insulinoma, which was previously occult, and you can actually see it when you look back on the diagnostic CT. There are additional investigations which may be required depending on the clinical circumstance. Mammography is no longer routinely recommended for female patients with cancer of unknown primary, but rather reserved for patients where there are clinical or pathological features suspicious of breast cancer. In women who present with malignant unilateral adenocarcinoma, but in the axillary lymph nodes, but no tumor on standard breast imaging, breast MRI has a very good detection rate for detecting occult breast primaries. Testicular ultrasound is beneficial for young men with poorly differentiated malignancy, particularly if they have large volume mediastinal retroperitoneal adenopathy, and tumor markers can help here too. And then MRI obviously is very useful in oncology imaging with its multi-parametric capabilities and excellent soft tissue resolution, but its use is really selected depending on clinical presentation and non-findings on initial imaging tests. And it is really most useful for improving lesion detection and characterization, and particularly brain, spine and liver imaging. This is an example of liver metastasis and MRI, which are almost completely occult on CT. So in summary, radiology plays a key role in the development and the evaluation of patients with cancer of unknown primary. A CT thorax, abdomen, pelvis would be the initial standard test to help find a primary site, characterize disease extent, look for a biopsy site, and of course, to try and find any benign mimics. FDG PET-CT is probably the next in line test, particularly in patients with head and neck tumors. And then to remember other tracers like gallium DOTA TOC in patients with metastatic neuroendocrine tumor. And then we have selective additional investigations depending on the circumstance, particularly breast imaging and testicular ultrasound, and then selective use of MRI. Thank you very much for your attention.